All right, I think it's showtime, so let's get started, everyone. Welcome to today's webinar, Diagnosis Chronic Pain. Understand invasive pain management interventions and their impact on personal injury cases. This webinar is hosted by Medical and Life Care Consulting Services, case management and nurse consulting firm headquartered in Massachusetts. We're excited that you've joined us for this presentation. My name is 𝐃𝐢𝐚𝐠𝐧𝐨𝐬𝐢, and I'm the moderator for today's webinar. This webinar is anticipated to run about 50 minutes, with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link to where you can access an on-demand replay, along with a link to a short survey. Please take a moment to complete the survey. Your feedback is valuable and helps us in the planning of our educational resources. We're excited to host today's webinar and look forward to an opportunity to partner with you. To kick us off, I'd like to introduce our speakers. Joining us today is Cynthia Bourbeau and Cindy Fleury. Cynthia Bourbeau is president and founder of Medical and Life Care Consulting Services, MLCC. She's a registered nurse, a certified rehabilitation nurse, case manager, nurse life care planner, and legal nurse consultant. She has worked as a nursing professional for 40 years and currently leads MLCC, a practice of professional nurse consultants and case managers who provide medical case management, medical legal services, including life care planning, and ancillary professional nurse consulting services. As a nurse life care planner, Cynthia Bourbeau has completed hundreds of life care plans, life care plan critiques, life care plan projections, and medical cost projections for both plaintiff and defense, insurance companies, and patients throughout the United States and internationally. Cynthia is presently a member of the American Association of Nurse Life Care Planners and is a board member on the CNLCP Certification Board. She is also an active member of the Association of Rehabilitation Nurses and the Case Management Society of America. Also joining us is Cindy Fleury. Cindy is a registered nurse, certified nurse case manager, and certified nurse life care planner. She's been practicing nursing for over 35 years, and her nursing experience includes acute care bedside nursing, to caring for patients in their home, to field case management and life care planning. Cindy has cared for patients with acute illnesses, recovering in their homes from an acute injury, as well as catastrophic illnesses and injuries. As a life care planner, Cindy has supported hundreds of medical legal cases as well, with injuries and illnesses ranging from failed back injuries, burns, severe traumatic brain injuries, birthing injuries, and spinal cord injuries. She's completed hundreds of life care plans, life care plan projections, medical record reviews, and medical cost projections. At this time, I'll pass it to Cindy Fleury to kick us off.
Good afternoon, and thank you for joining us. So I'm going to get started. So what is pain? Medically speaking, pain is an uncomfortable sensation that usually signals an injury or illness. Pain is the body's way of telling you something isn't right. This is the purpose of pain. It is meant to make you uncomfortable so that if you are injured or sick, you will know to do something or to stop doing something. The perception of pain varies from person to person. One person may have a broken bone and not even realize it, while another might feel significant pain from the same injury. That's because pain is mediated by nerve fibers in your body. And these nerve fibers have the job of sending pain signals to the brain. Once they find their way to the brain acts to make you aware of the pain. Because every person's body is different, their nerve fibers and their brain can react differently to the same stimuli. That helps explain why pain perception and pain tolerance can differ so much from one person to another. So what are the types of pain? There's acute pain. Acute pain means the pain is short in duration, lasting just a few minutes or to about 3 months. Acute pain also tends to be related to a soft tissue injury or temporary illness. So it typically subsides after the injury heals or the injury subsides. Acute pain from an injury may evolve into chronic pain if the injury doesn't heal correctly or if the pain signals malfunction. Pain is considered chronic when it lasts more than 3 months. It can be constant or intermittent. Chronic pain is often due to health conditions such as arthritis, fibromyalgia, nerve injuries, or spine conditions. According to the American Society of Interventional Pain Physicians, chronic spinal pain is the most prevalent chronic disease with employment of multiple modes of interventional techniques, including epidural interventions. Neuropathic pain is due to damage to the nerve or other parts of the nervous system. It is often described as shooting, stabbing, burning, or it feels like pins and needles. Neuropathic pain is a common cause of chronic pain. It can be intermittent or so severe that it makes performing everyday tasks difficult. It can interfere with normal movements, leading to mobility issues. Redicular pain is a very specific type of pain and can occur when the spinal nerves get compressed, inflamed, or irritated in the neck or back. It can radiate from the back and hip into one or both legs by way of the spinal root nerves. Cervical radiculopathy may cause pain in the shoulder or arms. Redicular pain may be accompanied by numbness, tingling, and weakness. So how is pain diagnosed? When a physician evaluates a patient to determine the pain generator, he or she will put the patient through different maneuvers to reproduce their pain. This is called provocative testing. What are the different exam tests that the physician will put you through? One is a straight leg raise. The patient will experience pain in the affected leg when raising the leg up at the hip when lying on their back. Positive findings indicate radicular pain or nerve involvement, such as a disc herniation, compressing or irritating the nerve. The slump test is just that. The patient is asked to flex at the lumbar and thoracic spine, extending the knee or dorsiflexing the foot on the affected side at the same time. If this produces the pain, that is a positive sign indicating radicular pain or nerve involvement. Perform a stretch. The patient is lying on their side and asked to bring the top leg up, bending at the knee with the bottom leg fully extended. Pressure is applied to the knee. If this produces pain in the buttocks or leg, this is considered a positive test, indicating the sciatic nerve may be pinched by the piriformis muscle. Fabre's or Patrick sign is when the patient is lying on their back. The hip is placed in flexion, abduction, and external rotation. So the leg is brought up and out, away from the body. The examiner applies pressure against the medial knee of the bent leg toward the table. If this produces pain in the groin or buttocks, this is considered a positive test and may indicate sacroiliac joint as the pain generator. Facet loading. The patient will be asked to extend backwards and rotate to the left or to the right. This loads the facet joints of the spine, and this reproduces back pain. And if so, it is suggested a facet-mediated pain. In general, pain provoked by flexing or bending forward suggests disc pain, and pain with bending backwards suggests facet pain. Sperling's test is used to evaluate for the cervical spine. The patient is asked to extend their neck, so look up and rotate their head right and left. If this produces pain radiating into the shoulder or arm, it is suggestive of cervical radiculopathy, so nerve compression or irritation from the neck. Patient with myofascial pain symptoms, soft tissue injuries, will experience muscle tightness and decreased range of motion. The physician will evaluate the muscle for tightness and limited range of motion. If trigger points are noted, typically there is an area of tenderness that when it's palpated, it will cause radiating pain. A trigger point can feel like a ball or a rope when palpated. Manual physical therapy is typically recommended for this type of pain. However, if symptoms persist, more invasive treatments such as trigger point injections will most likely be recommended. What diagnostic studies also can be recommended if the patient comes in and they've had the physical exam and the doctor wants to evaluate further. Next slide, please. They'll order some diagnostic testing. X-rays are the initial screening to evaluate for bones and joints, typically to rule out a fracture. CAT scans or MRIs of the spine evaluate disc or soft tissue of the spine. A CAT scan is better at evaluating bone, and the MRI is better at evaluating the spinal cord. An EMG is used to evaluate nerve function and can isolate a nerve involved. Back pain can be difficult to diagnose due to the multiple structures of the spine. If a patient has redicular pain thought to be coming from a specific nerve root but does not respond to treatment targeting that area, an EMG will be indicated to evaluate nerve function and further guide the treatment. Discograms can be used to rule out if discogenic pain is being considered. Disc pain is difficult to diagnose and treat. Patients with discogenic pain will have degenerative changes on their MRI, disc degeneration or collapse. Once conservative treatment, including injections, has been exhausted and the patient continues to have chronic back pain, a discogram may be recommended to confirm the diagnosis of discogenic pain. A discogram is performed by injecting directly into the affected disc to see if it reproduces the patient's typical pain. Discography can be extremely painful, and many patients choose to avoid this. Injections. Injections can be used both for diagnostic purposes to find the cause of the patient's pain or therapeutically to treat the pain or relieve the pain. The following injections are used for diagnostic purposes. A sympathetic nerve block or stellate block is used. During this procedure, an anesthetic is used and it's injected near the spine. This blocks the sympathetic nerves in that area, disrupting the pain signal to the brain. Pain relief of the affected area, usually an extremity, is suggestive of RSD or chronic regional pain syndrome. A medial branch nerve block is a procedure in which medicine is injected, again an anesthetic, near the nerve connected to the facet joints in the spine, blocking, disrupting the nerve signals to the brain. If the patient's pain is relieved, this is considered positive and diagnostic of facet-mediated pain. Lateral branch blocks is a procedure in which medicine is injected, again, an anesthetic near the nerves connected to the SI joint. If the patient's pain is relieved, this is considered positive and diagnostic of sacroiliac joint mediated pain. The length of pain relief following a diagnostic block depends on the type of anesthetic used. Typically, the physician will ask the patient to do a pain diary showing their level of pain immediately following the procedure until the pain returns back to baseline. A true positive test will correlate with the type of anesthetic used. If a short-acting anesthetic was used, then the patient's pain will return after a few hours following the injection. And if it was a long-acting anesthetic, then the patient's pain will return several hours later. Any injection in or around the spine should always be done under fluoroscopy or X-ray guidance. Non-invasive treatment. That's usually the course. The first line of treatment is something that's non-invasive. Physical therapy is most commonly recommended after an initial injury. Physical therapy should be geared towards the diagnosis. Many therapists will initiate strengthening before correcting any mechanical issues. A good physical therapist will do a full evaluation of their patient and correct any mechanical issues such as malalignment of the joints and/or muscle tightness or trigger points. If mechanical issues are not corrected prior to introducing strengthening exercises, this can exacerbate the patient's symptoms and impact the patient's response to treatment. Mechanical issues can be corrected with manual therapy and manual manipulation. Following an acute injury or surgery, the focus of physical therapy may be on restoring motion before introducing any strengthening exercises. This is important to avoid complications such as frozen shoulder, which can be a disabling complication and require more extensive intervention. Ideally, if the treating physician has on-site physical therapist, it is an ideal facility for the patient to treat, as there is direct communication and oversight with the prescribing physician. Aquatic therapy is sometimes recommended for patients that are not able to tolerate land-based exercises. Aquatic therapy may be recommended to implement strengthening and endurance exercises that can be performed in the water, so it's anti-gravity, prior to introducing more strenuous land-based therapy. Acupuncture is another form of non-invasive treatment. Acupuncture is a form of Chinese medicine. The general premise of acupuncture is that the body contains patterns of energy flow called qi. Improper flow of qi is considered to be necessary to maintain health. The theory of acupuncture is that there are over 2,000 points on the human body that connect with 20 pathways. These pathways conduct the qi throughout the body. With acupuncture, hair-thin metallic needles are inserted into specific combinations of these 2,000 points in an attempt to correct or maintain a normal flow of qi to facilitate recovery. Acupuncture treatment. Acupuncture adjustments is a procedure in which a trained specialist, a chiropractor, uses their hands or a small instrument to apply a controlled sudden force to the spinal joint, resulting in spinal manipulation. The goal is to improve spinal motion and improve physical function. Medication management is another option and can be effective with certain diagnoses. Efficacy of this treatment varies depending on the patient's response. Following an acute injury, things such as a non-steroidal anti-inflammatory, pain medicine, or muscle relaxant may be introduced. These should be used short-term. The patient does not respond to these initial treatments. Other medications may be introduced, such as neuropathic medicines to address neuropathic pain, as well as some antidepressants for chronic myofascial pain. There are also topical agents that can be recommended. There are compounding pharmacies that can provide a combination of topical medications, including gabapentin and anti-inflammatories together. However, these medications can be quite costly. If the patient has a good response, these medications can be prescribed long-term. However, the efficacy of the medicine should be significant enough to improve the patient's level of function. Routine follow-up every 3 to 4 months with the prescribing physician should be considered in the patient's life care plan. Given the opioid crisis, long-term narcotic use is not as prevalent as it was 10 years ago, although there are some patients that remain on narcotics long-term. The patient is on long-term narcotics. It's important to factor in routine urine toxicologies in the life care plan to ensure the patient is being compliant with the medication regime and not diverting their medicine. This should be done 2 to 4 times per year. Interventional procedures, injections, injection therapy, facet injections. These injections consist of injecting medicine into the facet joints, the joints in the back of the spine at each vertebral level, bilaterally, providing flexibility and stability of the spine. The medication used for facet injections includes an anesthetic and an anti-inflammatory, a corticosteroid. Unlike diagnostic blocks, these injections should offer long-term pain relief. Once the anesthetic is worn off, the patient's pain may return back to baseline. However, it should gradually improve over the next 2 weeks. Pending the patient's response, these injections can be performed up to 3 times a year. A favorable response is considered 50% or more improvement in their pain for an extended period of time, essentially 3 to 4 months. Sciatic, sacroiliac or SI joint injections consist of injecting an anesthetic as well as an anti-inflammatory medication, such as cortisone, into the SI joint. Some physicians will include the lateral branch blocks targeting the S1 to the S3 nerve roots. Unlike the diagnostic blocks, these injections can provide prolonged relief up to 3 to 4 months. A favorable response consists of 50% reduction in their pain for several months. Epidural injections is injecting a local anesthetic and a steroid directly into the epidural space that surround the spinal cord and nerve roots. There are 3 approaches for an epidural steroid injection. Transforaminal epidural targets a specific nerve, injecting medication, a steroid around a specific nerve root. The nerve is identified using dye under fluoroscopy guidance. Once the appropriate nerve is identified, then the medication is administered. An interlaminar epidural injection delivers the medication to the epidural space by directing a needle between the openings of the spine of the 2 adjacent vertebrae at a specific level. A caudal epidural injection injects medication into the low back through the opening of the sacral bone. There are different approaches to an epidural steroid injection, and the approach depends largely on what area is being targeted. Sometimes the physician will recommend an injection that will offer broad coverage when there's not a specific nerve root involved, such as a caudal epidural. If there's a specific level or levels, but not an exact nerve root affected, an interlaminar injection may be recommended. The injection goes between the openings of the spine at a specific level and will give broad coverage in that area. If the patient's symptoms are very specific to a specific location and nerve involvement, then a transforaminal epidural injection is typically recommended to achieve the best results. The purpose of the injection is to reduce inflammation or irritation of the nerve. Again, it can take up to 2 full weeks for the patient to notice any improvement. If the injection was effective, meaning the patient reported 50% improvement or more for an extended period of time, 3 months or more, then repeat injections should be considered. These injections can be considered for the duration of their life. However, no more than 3 to 4 per year is recommended. Physician visits should be included to correspond with the treatment. The patient should be seen prior to the injection for an assessment and to determine appropriate level and approach, and then a 2-week follow-up after the injection to evaluate the patient's response. If the injection is performed in the physician's office, the cost should include the physician fee for fluoroscopy, and the medication. If performed in an outpatient setting, the cost should include the physician fee and the facility fee. Trigger point injections are injections into the soft tissue. Physicians will sometimes do what they call dry needling, where they just inject the needle and insert it into the trigger point or the knot as a means of breaking it up and releasing it. Some doctors will use cortisone or lidocaine as well. Physicians typically do a series of 3 injections. Some physicians will order the trigger point injections to be followed immediately by manual physical therapy to further work out the trigger point. If effective, these injections can be performed 3 to 4 times per year. If including trigger point injections in a life care plan, you need to consider whether or not physical therapy will be included as part of the treatment. And if so, the initial visit for physical therapy and then weekly visits for 3 to 4 weeks should be included. The physician's cost should include the initial visit, 3 appointments for trigger points, and a follow-up appointment 2 to 3 weeks after the final injection.
The next page. So welcome everyone. I just wanted to say hello. I'm used to saying hello at the beginning, but I'm in the middle this time. So I'm hoping that you're hearing okay. We're doing this webinar at an alternate site and somebody's having a party next door. So we apologize for any interruption or problems that you're having with hearing. So let's talk about nerve blocks and infusions. The first one is a stellate ganglion block. So the stellate ganglion makes up part of your sympathetic nervous system and is located in your neck. It sits to either side of your trachea at the level of the C7 vertebrae. It connects to your central nervous system and helps regulate nerve pain. Stellate ganglion block administers medication in this area, both an anesthetic and a corticosteroid. So the sympathetic nerve block, for that, the sympathetic nerves are located along the front of side of your spinal column and help make up your autonomic nervous system. They take part in regulating neuropathic pain. A lumbar sympathetic block can be used to reduce the symptoms of CRPS in the lower limbs. The injection involves a combination of an anesthetic, a numbing medication, plus a corticosteroid and anti-inflammatory medication, which is injected near your spine to block the nerves. Both stellate ganglion and sympathetic nerve blocks typically require a series of injections. These injections are used to calm down the nerve and are commonly done in conjunction with physical therapy to desensitize the area. They are done in an outpatient setting under X-ray guidance. These injections are typically done 1 to 2 weeks apart in a series of 3. However, some patients may require up to 6 injections in a 12-month period. The next treatment is ketamine infusions. So ketamine reduces pain by interacting with a chemical receptor in the nervous system, blocking the transmission of pain signals to the brain. When this receptor is blocked for an extended period of time during ketamine infusion therapy, it reboots and stops interpreting peripheral stimulation as pain. So ketamine is administered by IV. Patients typically receive a series of 6 infusions over 2 to 3 weeks. Most treatments last on average about 2 hours. This is the induction phase of the treatment. The treatment is discontinued if the first phase is not effective. If effective, though, they move on to the maintenance phase. At this stage, patients typically return for 1 infusion every 2 to 6 weeks. The treatment can last as long as the patient shows improvement. When allocating for this treatment, the first 6 infusions should be included. If this is a new treatment, then you should include maintenance infusions depending on the patient's response. If the patient has been receiving ketamine infusions with adequate improvement, then it would be reasonable to include 1 infusion every 2 to 6 weeks, averaging that out to about 13 infusions per year. If this is a new recommendation that the patient has not yet trialed, then the initial trial of 6 infusions should be allocated, referencing in the report that if effective, an additional 13 infusions per year is recommended. This procedure is performed in an outpatient facility. Therefore, the cost should include the physician's fees as well as the facility fees. So when you're allocating for the sympathetic blocks in a life care plan, you want to include facility costs and the physician costs as these procedures are also done in an outpatient setting. If done in conjunction with physical therapy, you want to include the cost of an initial PT eval and then weekly visits to correspond with the injection, as well as an initial visit and follow-up appointment with the treating physician. Next slide. So other forms of treatment that we're going to talk about first are spinal cord stimulators. So what do you need to know? When is a spinal cord stimulator indicated? So this is used when non-surgical pain treatment options have failed to provide relief and no additional surgical interventions can be considered. Diagnosis of the underlying problem is critical to rule out any other pathologies or problems before this is considered. So testing should be done to rule out nerve impingement that could be resolved with surgery and avoid permanent impairment. If lumbar complaints, possible abdominal problems should be explored with a CAT scan of the abdomen or pelvis to make sure that a diagnosis is not being missed. So this is often one of the last attempts of pain management for this patient. It can be used for back pain, failed back syndrome, post-surgical pain, arachnoiditis, which is inflammation of the membrane that covers the brain and the spinal cord. It can treat angina, untreatable by any other means, injuries to the spinal cord, diabetic neuropathy, cancer-related pain from radiation, surgery, or chemotherapy. It's also used for peripheral vascular disease, complex regional pain syndrome, and pain after amputation, as well as abdominal pain and perianal pain from a variety of injuries to nerves. So screening for this includes a psychiatric evaluation to make sure that the patient doesn't have any psychiatric disorders that would decrease the effectiveness of the procedure. So what is the process? The first step is the trial. The surgeon will implant a temporary device under fluoroscopy and insert electrodes in the epidural space of the spine. You may be asked for feedback so that the doctor can see how the patient's pain responds to the placement of the electrodes. The battery in this trial or the generator is outside the body on a belt that you wear around your waist. You utilize this for about a week, and then the trial is considered positive if you have 50% or greater reduction in pain. The electrodes are then removed, and if it's considered successful, then you go to have the stimulator implanted. The implantation is done as an outpatient procedure under anesthesia, and the incision heals in about 2 to 4 weeks. Usually you're allowed to return to activities and work 1 to 2 weeks after the procedure. The stimulator is not turned on immediately. It's turned on by the surgeon in the post-op visit, which is usually about 2 weeks post-insertion. So potential complications from this are the usual: infection, bleeding. In this case, you could have device migration. So maybe the electrodes move from their original location, device damage. You could have dural puncture with CSF loss and headaches, or even spinal cord trauma resulting in nerve injury and paralysis, although this is very unusual. The purpose of this stimulator is like everything else that we do in rehab. It's to improve the quality of the patient's life so that they can live that life with as little pain as possible. In addition, this affects so many other aspects of their care. It can result in the decrease in oral medications for pain, which cause sedation, dependence, GI or constipation problems, poor sleep due to pain, etc. It is never just used alone, but is used with other pain management techniques. A big question that everyone has when this is put in is, can I have x-rays or CAT scans? These can be completed if the stimulator is powered off. You just have to let the doctor or technician know that you have a spinal cord stimulator. MRIs are a different story, and what type of stimulator you have makes the decision about what you can have done. Some devices are compatible with certain MRI machine models and scan locations, and your doctor will tell you whether yours is compatible with MRIs, because if you have one, the MRI can cause some serious injury. Sometimes with a lumbar placed stimulator, you can only have MRIs of the head. Your kit that you get when you get the stimulator will give you a card to carry to give to the technician, letting them know you have a dorsal column stimulator. It has instructions on what you need to do for an MRI of the head. Airport security gates will detect the spinal cord stimulator. So you have to have your patient bring their card with them. That may allow them to bypass security gates. If they need to go through, they just have to turn off their device before stepping through. So a spinal cord stimulator is made up of electrodes, thin wires, and a small pacemaker-like battery pack, the generator. The electrodes are threaded up the epidural space, placed between the spinal cord and the vertebrae. I've had patients where the physician has not found that there's enough room in the epidural space, and they have to implant them percutaneously, and so that's the physician's decision. The generator is placed under the skin near the buttock or abdomen, and the electrodes are connected to the generator. An external controller can then be used to turn the generator on and off, initiating electrical impulses when they feel pain. So how it works. Once the wounds heal, the controller and stimulator are turned on. Some patients have intermittent pain and they can use it just when the pain occurs, but others have constant pain, which is a challenge. The stimulator interrupts the pain impulse both as it goes up the spinal cord to the brain and then from the brain back down to the initiating pain site. The stimulator replaces the sensation of pain with a slight tingling, causing like a paresthesia. With some of the new models that are now available, patients feel no vibration or tingling at all, but do indicate that they feel a different feeling than the pain. And this is how they know it's working. And they can be used intermittently or continuously. After the permanent stimulator is implanted and you've healed, your physician and the stimulator vendor assist in helping you choose the channel that you would use. So different body positions may require different stimulator settings, such as one setting that works better for sitting and another for walking. Most devices allow you to save 2 or 3 preset programs, and the newer devices also have several different waveforms. for electricity delivery, such as high frequency, burst, and high density stimulation. And so they can go across the spine, they can go up and down along the spine, and they can do an intricate pattern of impulse. So there's different kinds of spinal cord stimulators that you need to be aware of because some are newer than others. A conventional implantable pulse generator is a battery operated spinal cord stimulator. A battery is placed in the spine during an operation. And when it runs out, the battery has to be replaced with another surgery. This can be a good choice for people with pain in just one body part because it has a lower electrical output. The second type is a rechargeable IPG, which works similarly to the conventional device, but the difference that the battery can be recharged without another surgery. Because the energy source is rechargeable, these stimulators can put out more electricity. And this may be a better choice for people with pain in the lower back or in one or both legs, as the electrical signal can reach further. With this type, the patient changes the battery, charges the battery and charges the controller. They're both separate charges. So depending on its use, the battery could need to be charged 2 to 3 times per day. The charger is an external ring. It is recharged from the controller. The stimulator continues to stimulate while it's being charged. So you never want the charger to get down to close to 0, then it takes longer to recharge. The radio frequency stimulator uses a battery that's outside of the body. And this is rarely used today because of newer designs and better technology. It has rechargeable batteries, and like the rechargeable IPGs, it may be better for people with pain in the low back and legs because of the device's power. So when a dorsal column stimulator is implanted, make sure you know what type you're getting, as each has different frequencies of replacement. Some people use it for a period of time, and because they're able to increase their activity, their pain problem resolves. They increase their functional status, they exercise, and were able to correct the problem or the area healed. Other patients use them throughout their lifetime. A conventional non-rechargeable stimulator is changed every 7 years. A rechargeable IPG can last 10 to 25 years before a revision needs to be done. So depending on what type they have would determine how frequent replacement is put in the life care plan. Although I do feel that we should always, as life care planners, put an extra revision in there, even if they only need one, like they've had one implanted and you know they're not going to live another 20 years. There's always the chance of there being a malfunction of that equipment, so you want to make sure you cover that. And then the last area is intrathecal pain pump. And a pain pump is a surgically implanted device that delivers medication directly to the fluid surrounding the spinal cord. This can interrupt the pain signal traveling through the nerves and the spinal column to the brain. So this is appropriate for patients living with severe chronic pain or spasticity that is not controlled with other methods, or the level of medication that they are getting are causing too much sedation and they cannot tolerate the amount they need orally. So diagnosis treated can include back or neck pain, pain after a surgical procedure, abdominal or pelvic pain, extremity pain, complex regional pain syndrome, trunk pain, including pain after shingles, cancer pain, either from the cancer itself or from the treatments, neuropathic pain, spasticity due to MS, CP, or brain or spinal cord injury. People who qualify are those that have failed other methods of pain relief and require pain or spasticity medicine around the clock. They need to expect to live longer than 6 months, do not have a substance abuse disorder, or they also do not have increased intracranial pressure or psychiatric illness. So all of these things are looked at before a pump is implanted. So it is made up of a medication reservoir, a pump, and a catheter. It delivers small amounts of medication directly to the central nervous system. And it does this by pulling medication from that reservoir placed in the abdomen and pumping it through the catheter placed in the intrathecal space, the subarachnoid space of the spinal cord. The intrathecal space holds the cerebral spinal fluid that bathes the spinal cord. Because it delivers medication directly to this area, powerful relief can be obtained with much smaller doses, and as a result, it can reduce medication side effects that long-term use of pills can cause. So how does it work? Surgically, a catheter is inserted into the intrathecal space surrounding the spinal cord. An extension catheter attaches to the catheter in the intrathecal space and goes around the torso, as you can see from this picture, where it attaches to the pump. The pump is round, flat device. It's a disc about 1 inch thick and 3 inches across. It's a hollow reservoir that holds the medicine. And the pump is implanted in a space under the skin of the abdomen. As it is used, it's refilled in a physician's office and accessed with a needle. Depending on the size of the reservoir and how much medication is needed, determines how often it needs to be refilled. So a patient could start out with a pump with a 20 cc reservoir, but with increase in the amount of medication or the bolus doses that they can get, they may need to go up to a 40 cc reservoir. So prior to implantation, a trial could be done for this in several ways. One is a dose of medication can be placed in the intrathecal space with a lumbar puncture. Or they could do multiple. Some physicians require multiple doses be placed to see what the effects are. In addition, a catheter can be placed in the intrathecal space and connected to a pump that is not implanted in the body. So they can trial that in that manner. If the trial is effective, then the pump is implanted surgically in a day procedure. The body needs to heal, but a low dose is started prior to discharge, and then frequent visits to the physician's offices are held for increases in evaluation of the patient's response to the medication. Complications are rare, but they can include infection, a CSF leak, or mechanical problems with the pump or shifting of the device after time. I had a patient whose spasm increased and everything looked good on MRI or X-ray, and with accessing the catheter and flushing it, but when they went in and revised it, they found that he had 𝐃𝐢𝐚𝐠𝐧𝐸𝐢𝐴 tubing. So usually if there's a sudden increase in pain, something's causing it. So how does it work? The pump is refilled in the physician's office every 2 to 3 months, depending on the use and the size of the reservoir. And that's determined, by the physician's office. The residual medication is removed from the pump and the new medicine is put in. The pump is set and adjustments to dosage are done at that time. An alarm date is determined, and this is the marker for getting the pump refilled. Most physicians require that it gets refilled 2 weeks before the alarm date, as if the medication runs out, it can cause a severe problem. So if it's pain medication, the patient's pain can get severely worse, but even more serious is if it's baclofen or something to stop spasm, then it can be life-threatening, so we have to be careful. Just like a dorsal column stimulator, this will set off metal detectors, and the patients get an identification card that they must keep on them at all times. An intrathecal pump lasts 5 to 7 years, and when the pump is accessed, the physician can access a battery reading, and he's able to calculate what year that the pump needs to be replaced before it stops working. And that's usually a deadline that's set in place in the patient's record. With an intrathecal pump, you are able to have an MRI. You must inform the technician that you have a pump, and an appointment with the pain physician needs to be scheduled for immediately after the MRI, as the pump may stop working and may alert you with an alarm. It will start working, it usually will start working after the MRI, but it needs to be checked and restarted if it is not restarted. And as I said, this is especially critical with baclofen medication because this can be life-threatening. So with patients that I have that have a baclofen pump, I make sure they have oral baclofen available in their house. So in the event that the alarm goes off, they can take some baclofen because you don't want there to be any crisis that occurs. So how to allocate long-term treatment for chronic pain into the life care plan. So obviously this is a personal decision that every life care planner does when they do an evaluation. The treatment plan is determined by the patient's history, their symptoms, and their present treatment plan. And there are hundreds of combinations of treatments that can be outlined. You should not be opening a book and outlining every single item that's listed there. It needs to be very patient specific. And the determination is built on the patient's treatment plan, present treatment plan, and what can be reasonably expected to occur in the future. Your opinion should be based on what the patient has responded to and how often the medication treatment can be completed. Consultation, when possible, with the treating physicians is key. If you can't, because you're on the defense side, speak with the treating physicians, then an expert who's been retained by the defense should be contacted if it's not clearly identified in the patient's treatment record. And obviously your experience as a treating practitioner in your field really matters and can support your plan also. So that's basically
all right. We are at our Q&A segment. So thank you to both Cynthia and Cindy for sharing so much information today about pain. At this time, we will shift into our Q&A session. And I do invite you to submit those questions using the Q&A feature. That way we can track and make sure that we've responded to them all. Additionally, on the lower right-hand side of your screen, there's a QR code, which I invite you to scan with your cell phone using kind of your picture or function, which will take you directly to a very short survey, but really gives us a lot of good feedback on the type of content that we're presenting. So let's dive in. We've got some questions in our queue. The first one is, insurance doctors are testifying that discograms are no longer recommended in determining need for surgery. The discography controversy is being used to defend against surgical recommendation. Are you seeing insurance physicians recommending authorization for discogram being denied in your geographic area?
So, you know, both Cindy and I are here together. Cindy Fleury is here with me. Both Cindy's here. So I still see physicians requesting discograms, but I don't feel that they're being done as often now. Do you agree?
Yes, I agree with that.
Yeah. But when they are asked for, I have not been seeing denials, actually. I have been seeing them being completed. I think that everything you put in your plan can be challenged. And I think that there is still, any treating physician would still say that there is still basis for evaluation by discogram if they aren't 100% sure with the other evaluation techniques available. So I am seeing that it is being completed. I don't know if that answers your question, but jump in if we didn't.
No, I would agree that it's not.
Thank you.
It's not as prevalent as it used to be.
Thanks. Here's another question. How successful is ketamine treatment for CRPS in your opinion? If you could share any percentages of outcomes.
So I have had patients get ketamine infusions. I had one patient who had a great response to treatment for that and relief of their symptoms with other treatments involved. A lot of people are leery about doing the ketamine infusions because of the dreaming and hallucinating that they do. So I don't feel that a lot of people want to explore that option. That's what I find more than anything. I've had a few people that have done it, and I haven't had anyone long-term who has chosen to do it long-term. I guess I could say that.
Okay, thank you. I have another question. Can you use a spinal cord stimulator and a baclofen pump at the same time?
So yes, so dorsal column stimulators are used for a multitude of things, right? So you could have 2 dorsal column stimulators implanted actually. And I know that not in the United States, but in other countries, they're using that to stimulate the spinal cord to see if it can facilitate movement and regeneration, which is kind of an interesting idea. It's not FDA approved in this country, so it's not really, it's not an accepted treatment, and patients tend to be reaching, their families tend to be reaching and trying to see whatever's out there to see that would help in that circumstance. But yes, dorsal column stimulators and the ports are put in place to get, not at the same time, but usually one option is trialed first. Sometimes you have a patient that has spasm, but then develops a central pain. Anyways, that's about that, I think.
Thank you. Yeah, one more question, actually a couple more questions. Is discogram effective in diagnosis? Not the dangers, but does it work?
Yes, I think it does. Yes, I think it can be diagnostic with someone with true discogenic pain. And sometimes actually when they do a discogram, sometimes they'll actually include like a cortisone medication to try to calm down any irritation in the disc itself.
They're very painful procedures. Nobody likes to get them. I cringe when I see patients getting them ordered. But physicians do still use that technique, that test, so.
Okay. We have another question. How do you determine the number of injections to put in the plan?
That's the big question for everybody, right? I personally very much base it on what the patient has been doing and what their treating physician recommends. I think that I've been working with patients for 42 years. And so I have found over the years that treating with people long-term, because I've had patients up to 17 years before they passed away. So I see a cycle of complications and exacerbations that happen during that time. And so I oftentimes will put in a certain rate of repeating treatments. People aren't going to do anything continuously, I don't feel. But there will be periods in their life where they will have exacerbations, whatever the problem is. I mean, it could be any body part. So you kind of use all of that as a combination. Can I give you a set number of every single treatment? No, I can't, because it's so individual to each patient. Do you agree, Cindy?
All right.
Yes. It's individualized for sure.
Don't you love that? That's real conclusive answer, and I'm sorry, but
Look at their history and, you know, how many injections have they had? Is it helping them? You know, what kind of relief are they getting? If someone's getting an injection and it's giving them 6 months relief, then, you know, twice a year seems appropriate.
And really, the plan is really supposed to be for the patient, right? Even though we're in this medical legal arena, we do a lot of plans that are not included in legal, but, you know, the focus of every one of these plans needs to be the patient and what is going to be effective in giving them the best life possible while they're dealing with whatever has happened. So yeah, I think if you keep that in mind, you'll find your answer.
Nice. All right, we have a few more minutes, folks, and I invite you to, one, submit your questions. You can use the Q&A function within the Zoom dashboard. I also ask that you scan the QR code on the lower right-hand side of your screen and submit our the survey for the webinar. Your feedback is really, really powerful for us. We see ourselves as not just partners in this arena, but also a resource for our clients, right? So we want to make sure that we're providing you access to information to get your questions answered. So I will give it another minute or two for questions to come in. I'd like to just remind you that if you do have a case and you just want to ask a few questions, our consultations are free. Medical and life care consulting provides comprehensive life care planning, medical chart reviews and chronologies, medical cost projections, focused estimates of care. This is really good if you just want to understand really specifically about, one injury or something. Medicare set-aside allocations, and as you would expect, we have a legal nurse consulting team as well. So if you have a case, don't be shy. You can either send us an email at info@medicalandlifecare.com or pick up the phone and call our office, and we will get you scheduled with one of our experts. We have another question that has come in the queue. Have you seen disc replacement surgery? Is this an option?
Yes, I think so. Absolutely.
I've had patients who've had them.
Some people don't want to proceed with surgery, and they're afraid of it. So, but it's a good option, and I think the outcomes tend to be pretty favorable.
Yeah.
Okay. Any final thoughts?
I just want to say thank you all for joining us. And if you're life care planners, maybe we'll see you at a conference sometime or an attorney. We'll really look forward to meeting you in the future. Feel free to come up and say that you've participated in one of our webinars. We'd love to hear that. So thank you.
Yes, absolutely. All right, thank you for joining our first medical legal webinar of 2023. There are 3 more planned for the rest of the year. So if you take the time to do the survey, you also get to preview the dates for the next sessions and the topics. A playback of this webinar will be available within 48 to 72 hours. Additionally, or finally, please take the time to complete the survey. And thank you again for your participation. All right, everyone, have a great rest of your day.